About head and neck CT for radiotherapy. So radiotherapy, if you don't know, means you're exposed to ionizing radiation in order to kill cancer cells, okay? As you know, radiation can take many different forms. Sound is a form of radiation. Heat is a form of radiation. Light is a form of radiation. But the ones we're interested in, medicine, tend to be, they don't have to be, but they tend to be what's called ionizing radiation. For instance, like X-ray or CT, okay? MRI is another form of radiation, but it's magnetic, so it is different. So the radiotherapy is something that, hopefully none of you have experienced, certainly hope, and hopefully you will never experience it in your life. But unfortunately, you may, or someone in your family may. And you would think that radiotherapy is something that's very precise. But it's not. It's not. It has definitely improved. But unfortunately, it's very challenging to expose the exact targeted area in which you would like to treat. And unfortunately, early radiotherapy resulted in more damage than actually improvement, okay? So you can thank all the poor patients who suffered before now to teach us how to correctly do radiotherapy. So the first thing we do is identify and diagnose, and that's not what we're talking about today, because we've been talking about that all for the last few days. That's diagnosis, right? So that's exactly what we talked about this morning, is how do you detect and delineate the tumor. But what we're going to talk about now is image acquisition, which is a CT. It's that easy. How we define the organs at risk. Then calculate the dose, so meaning how much radiation is required to do the treatment. Deliver the radiation, of course, which you'll think, that's so easy. No, it's not. And then monitor and reassess afterwards, right? So this is just, that's a clinical perspective of what is done. But inevitably, our interest today is how can we introduce artificial intelligence into this process, and you will not be surprised to know it is a very interesting area of the application of AI. So it's not new, it's not like it's something, no. Biophysics, that comes under medical biophysics, and there's a lot of it being done. So no surprise. So cancer treatment using high energy rays to destroy cancer cells, we've just went over that, that's what it's all about. And it's damaging the cancer cell DNA so they can't grow or multiply. That's the goal, right? So cancerous cells are actually it's a really simple problem, right? It's dysregulation. It just means that your cells are growing when they're not supposed to be. It's really not a big deal. A lot of people think that cancer is this really weird, foreign, alien in your body. It's not. It's actually your own cells, but unfortunately they are replicating uncontrolled, unchecked. And in some cases, it's actually not a huge problem. But in other cases, if they migrate to a different area in your body, it's called metastases, and it migrates to your brain, then you get a brain tumor. And that's unfortunate. So we want to try and kill what's called the primary cancer. So that's where you first get your cancer immediately. Because if you do, before you get metastases, the chances of survival are much, much greater, like really good. If you get metastases, the chances of survival are not great. So I'm a statistician, right? So don't always remember as well, whenever we talk about this, it's just a probability, it's time. So when you say survival, we are all going to die. It's when. And that's a very interesting concept in medicine, right? You want to delay your death as long as possible. That's the concept of medicine. We are all going to die, as you know. So, you do need to keep that in mind, especially when it comes to quality of life, right? There's those, I'm going to talk about that tomorrow, actually. So, a quality of life trade-off, right? So how willing are you to trade time for good health? It's an interesting concept that in medicine is very important because treatments can either improve everything or it can treat the disease but make life terrible. So, painful, lots of pain, lots of... So you do need to keep in mind that, and cancer is one of them, right? Making those decisions, and I'm going to talk about in the next lecture, I'm going to talk about traumatic brain injury, where you unfortunately have to make decisions like that. Okay, so the advantages of radiation therapy is it's localized, right? That's the whole point. We're not irradiating the entire body, because then it would be easy and you don't need AI, right? That'd be like sunbathing. You're irradiating your entire body on the beach, right? So there's no targeted anything. But in our case, for what we want to do, is we want to target exactly where the cancer is. Chemotherapy, on the other hand, tends to be one of those everything. You're treating the entire body, right? Because it's an infusion. It is targeting actively, dividing cells, so there's a little bit of target there, but it is still your whole body that gets exposed. So inevitably, what you want to look for is reducing the risk of complications from surgery, while preserving organ function and structure. It's really good if you have an inoperable tumor, so a tumor that cannot be excised. Then radiation therapy is a good solution. It should shorten your hospital stay if everything goes well. And targeting microscopic cancer cells, yeah, if you can identify them, and that's the problem. Okay, but if you can't identify them, then perfect, you can target it. So that's the advantages of radiation therapy. So adjunct therapies, this is just standard now. Okay, so combining surgery, chemotherapy, and radiation therapy is pretty much, and I'm not an oncologist, but pretty much most cancers that I know of that have a tumor, growth, you get all three. Okay, it's a combination of chemo, surgery, and radiation. And generally, before surgery, the plan is to shrink the tumor, all right, to a manageable size, smaller, so it's easier and less invasive on the surgery. And then after surgery, to be sure you've killed off those cells, you're going to usually go through chemotherapy. Okay? And all of this is just to get rid of those annoying cells that are just replicating unchecked. Okay, so we carefully already said this, symptom relief for the medicine. Okay, so palliative care, so those of you who don't know, palliative care means care of a patient before imminent death. Okay, so meaning that the patient is done, and they will die in hospital, and that's what palliative care is. So it can be used as well for exactly that, to ease pain. All right. So what's the pipeline? I think we just kind of went through it, but just so you see it visually, identify and diagnose, image acquisition, define the target. That's the most important thing that we're going to talk about. Plan and calculate the dose. As you can imagine, AI is perfect for that. Right? Deliver the radiation. Do you think AI can be used in that? Can AI be used in the delivery of the radiation? What do you guys think? Yeah, absolutely. Why not, right? Because it's coordinates, right? You have to actually direct the beam exactly where you need it, and so that can assist in positioning, right, the beam. And then monitor and reassess. Do you think you can use AI in there? Monitoring, reassessing? Yeah, why not, right? Why not? Absolutely. AI can be used in that. And that's something that's probably nice, right? Because patients get discharged, right? So they come in for treatment. They're not even admitted, depending on the severity. They're not even admitted, right? So it's a day thing. They go in, they get an infusion. If it's chemotherapy, they go in. If it's radiation, they go in, they get irradiated, they go home, right? So when they're at home, it is kind of nice to, you know, have some form of connection with them, where you can assess what's going on. And I'll show you why. You might be thinking, well, yeah, okay, but they're done now, but they're not, and I'll show you why. So we're going to start with the image acquisition here, okay? So we need to know exactly where the tumor is, how complex it is, and we need, of course, as best possible precision, so image position, right? So we use, typically it's CT, all right, that is done. MRI can be done as well, for sure, but very often it's CT. Or both, right? And by using this, not only we locate, but we also do the planning. And I'll show you why there's a planning. So when you scan the patient, there are specific parameters that are used so that we can use that CT for planning. And then just keep in mind, just like what we talked about this morning, so for you AI developers, you machine learning developers, you're going to have a scan range, you're going to have a slice thickness. Remember we talked about slices, so depending on your CT. You're going to be working with a reconstruction algorithm. Breathing instructions. Why would there be breathing instructions? Just so the patient doesn't panic? Why would there be breathing instructions? And immobilization devices. Why would you have that? Why do we need that? Is that just for Zen? You know, like just to relax? Is that why we need breathing? Why would we need breathing instructions in this case? Anybody? Movement, right? So if you have movement, inevitably, your ability to localize, or just image acquisition for that matter, movement is going to cause blur, right? And then your ability to localize a tumor, especially in the chest cavity, is a huge problem. So has anybody here had an MRI or CT? No? Yeah? So, you know, you're asked, you know, okay, hold your breath, you know what I mean? And then especially if it's MRI, it's just, you know, you get like headphones on, because it's not terribly noisy, but it's pretty noisy, and you're in there for a while. You're in there for like 40 minutes, you know, typically. And so it's kind of annoying. I know sadly I've had many MRIs, and I fall asleep in all of them, like all of them. And then they have to wake you up because they don't want you asleep in an MRI. They want you awake and not moving instead of like kind of waking up like that. So anyway, so it is important you do that so that you get the best picture possible, okay? That's the reason. Immobilization devices is exactly for the same reason. It's to stop you from moving so that you don't inadvertently ruin the skin. Okay, so what are we looking for? Most importantly is reproducibility of patient position and anatomy. So why is that? It's because, as I said earlier, you can't get your radiation in one go. So when you calculate the dose required to shrink or destroy a tumor, unfortunately, the dose required is such that if you were to deliver it in one go, you could actually kill the patient. Too much radiation in one go. You will absolutely kill the tumor. There's no doubt about that. But you're also going to be, you know, making coffee right next to the patient, and the patient's going to die, right? So it's too much energy, okay? And so the reason that becomes a problem is because they're going to come in for 2 weeks or longer, right? And they're going to have to come in multiple sessions. And each session, you need to continue the treatment exactly where you left off to get the job done. So that's where what we do is very helpful, okay? Because previously, it was done as best they could, right? So they would position exactly, you know, they could take pictures, and they could take positioning, they could take coordinates and all that stuff, but we didn't really know what was going on inside. So that's what you know, all of the medical imaging, radiology, right? Radiology is simply inside your body photography. That's all it is, really. It's just taking pictures inside your body. So the ability to take a picture inside your body and to interpret it for positioning, you would think is easy. It is absolutely not, and it is still even today extremely challenging. To be able to know where you are in 3D space inside your body is not an easy task. It's very complex. And so that's why, as soon as you hear complex, you should be hearing, that's my job, okay? Because that's where machine learning and AI does a really good job, is in complex problems, okay? So knowing the exact same coordinates is very important. And precise imaging, in order to make sure you don't damage what's surrounding it, is the goal. But get this, the subject you are working with is a patient, correct? What do you think happens over 2 weeks to a month? Or what can happen? Your patient's going to change, right? A, they're ill. They're actually suffering from radiation poisoning because you're irradiating them, so they feel horrible. So what are they going to do? What do you do when you get sick and you don't feel well? You don't eat, right? So if you don't eat, you're going to lose weight. You're going to lose muscle tone. So when that happens, what happens to all of your lovely work that you did? You spent so much time trying to map exactly where you need to irradiate. But when that patient comes in, you lie them down on the table in exactly the right way, well, the tumor moves. So you keep going, you're zapping away. And what are you doing when you're zapping right next to the tumor? That's a problem, okay? And so there's another complexity. Is not only do you need to plan and find, but you also need to estimate changes, okay? So there's your planning CT to find the mass. There we go. It's weird, the funny, yeah, it's okay. None of us have, hopefully, none of us have epilepsy, because that could definitely be a trigger. So when we go planning CT to find the mass, the patient's position is slightly different than the planning session. Happens all the time. Happens all the time, right? And then radiation applied to the wrong area. That's just, it doesn't look like that. But, that's just to say, oops, you irradiated the wrong place in the brain. So you would say, who cares? Because the cancer is worse, right? You're going to die from the cancer. But I would say, no, it's a problem, right? If you're irradiating the wrong tissue, that might have been okay like 50 years ago, but it's really not okay now, right, to irradiate the wrong tissue, all right? Because quality of life, I'm going to bring it back to quality of life all the time. Quality of life is really important. So this is a personal reflection, okay? If I had a brain tumor, I would only undergo treatment if truly it was looking like I would, survive it. And I would have quality of life. Because if I had the risk of going through irradiation and then not having quality of life because you irradiated, the motor section of my brain where I'm going to lose, function of my arms and legs or something, no thank you. No, really, I mean that. No thank you. I'm not interested. I'd rather die from my tumor because we're all dying one day, so it's just time, right? So do I really want to prolong my life for another, 15 years, but I'm not functional anymore? Do I really want that? Right? So you do, as someone in the healthcare field, you really need to consider that, right? And then you building the software, that should be a motivator for you, right? That's what should motivate you, is that's the reason you're doing such a great job, is that you're avoiding this, okay? So this is, we've just talked about that, but ultimately it's laser alignment. So this is interesting here. So this is just to show you mathematically how it can, just the position of the head can make such a big difference in terms of where you're, in 3D space, what you need to, the target you need to hit, right? Even shoulder positioning, if the mouth is open or closed, like this is just silly, if you're in the medical field, you'd be like, oh, come on, I know that. But, for you guys, for you engineers, you may not be thinking of these things, right? Or even when if you bite down on your teeth, you actually bunch up, right, your muscles here. And that changes things. That will change structure. And you want to avoid motion, of course, you've already covered it. So there's these really cool things that you probably don't know about because you haven't had radiation therapy. Good for you. But you have what's called thermoplastic masks. So these are really cool because they're molded to you and they fit. And what it does is it provides the people that are setting you up, the ability to position you and to have coordinates. Okay, so that's what these are for. And then you have these bite blocks, right? Headrests and shoulder pulls. So that's all to just keep you in the position you're supposed to be in. And then here, it increases reproducibility for your treatment setup. So this is a job. So I don't, do we have like, you know, radiation therapists or, you know, CT, MRI, operators, technicians, technologists, they all have different names. Is there anybody here in that area? No. So that's a big area, right? That's a really big and interesting area to work in, is exactly that, because you need to learn how all of it operates, and you have to, and you're the operator, you're the one who's doing this. So it's an interesting job, and that's what these guys are going to be doing, okay? All right, so let's get down to some imaging. Here, for those of you who don't know, in CT, you can have CT with what's called non-contrast, or you can have a contrast-enhanced CT, and so that's an injection, okay? Contrast agent that's going to increase the contrast in your blood, and so that changes the look depending on the distribution of the contrast agent, okay? And so you do that so that you can better identify the tumor, okay? And so there's an idea, so that's a form of image enhancement, right? You're trying to, you know, clearly get a good handle on the targeted area. And so there's just a very basic way. And so I'm showing you guys because that's what you're working on, right? So that's your target. Okay. So then once you've done that, you're going to then come into the problem that we talked about this morning, and that is segmentation. So Ernest gave a lovely talk about it. And so in this case, the application of what he was talking about is exactly this. Your gross tumor volume is here. So that's the exact tumor, which is what Ernest showed. So that's what he was working on, the segmentation of the actual tumor. Okay. But in our world now of therapy, radiation therapy, we're then going to look at what's called the clinical target volume, which is just bigger. So it's just outside. So why would I do that? I don't want to hurt healthy tissue, correct? So wouldn't it be the opposite? Wouldn't I want to make it smaller than the tumor to make sure I don't hit healthy tissue? So why am I going outside of the tumor and purposefully irradiating healthy tissue? Why am I doing that? Anybody? So, metastases, yeah. So, exactly. So what we don't know is we don't know actually exactly where the tumor ends and healthy tissue begins. So we incorporate a margin of error, and that's what this is. If we actually could, at the cellular level, you know, poke along and test and test and test and test, then you probably could get to a very small margin. Right? But because this is visual, we really don't appreciate where the actual tumor ends. And so for that reason, you have to irradiate a larger area for exactly that, for metastases. So meaning that if you leave tissue in there that's malignant, then it will grow back. If you leave tissue in there that's malignant, it can metastasize and float off, especially when you damage the tissue. Okay, so metastases is just single cells that break off, get into your blood flow, and then go and lodge them somewhere else, and they seed somewhere else. Okay, so as I said, for breast cancer, it's common that it will get into the, you know, float around and lodge in your brain. Right? That's just unfortunate. It's called secondary cancer. So that's what you want to avoid. Then we have the third one, which is the planning target volume. And so once again, you got to go even outside of your margins for planning. Okay? So that's like your workspace. That's what the planning is for the workspace. Okay? For safety, essentially. Okay. So why are we doing this? Preservation critical for speech, swallowing, vision, and hearing. You do not want to affect areas of the brain when you're zapping away that could lead to death, essentially, or could lead to a real loss of quality of life. All right, that's the purpose for what we do. And specifically, obviously, these ones are critical. Speech, swallowing, vision, and hearing is kind of the main areas that people, so, it's all preference, but, so motricity, areas of motricity are a little less emphasized because, you may have a little bit of a tremor, I'm not saying you're going to be completely quadriplegic, but you may just lose, you'll get a little numbness or something like that, and you're like, well, that's okay, I can handle that, right? But losing these ones, swallowing, it's a big one. You really need to swallow, right? So there's just certain things that you can't. Vision, speech, and hearing is just such a decrease in the quality of life that you do need to be aware of it. Okay. So let's talk about problems that you as engineers need to be aware of and guide, but it's not your problem. What it is who are you asking to contour? Okay? So if, let's say you didn't exist as engineers, how would we do it? Well, we would show these scans to experts, typically radiologists, or I'm drawing a blank here. There's a section in radiation therapy that's for radiology. Radiation oncology. Thank you, sir. It's, my brain will. So radiation oncology, exactly right. So, but it's the same task, right? If they're radiologists. It's funny, there's a bit of a competition, because I'm in medical imaging, which is radiology. And I have actually students that have gotten into radiation therapy or radiation oncology, and of course, radiology. And it's the same with cardiology, right? So cardiology does their own imaging as well. So it's just kind of this struggle, right, of who gets it. But essentially, it's the same job. So what we're doing here is we're reading the scans, those CT scans, for identification of the tumor, and then we ask them to segment it. And then those segmentations are taken by the planning team, and then they're going to draw the margins, and they're going to draw the planning margin. Correct? So why am I bringing this up? How well do you think radiologists agree in general? Do you think it's good? What do you think? Who thinks radiologists agree quite well? Let's say greater than 90%. No, okay. Greater than, again, somebody has to put their hand up at some point, right? Greater than 80%. Greater than 70%. Oh, 70%. Okay, you guys are 60%. 50? Okay. So it's about, it's about the 60 to 70% is kind of where, it really depends, right? But on average. So that's low. That's terrible. It's really bad. And the reason being is because we're all different, right? We all have different perceptions, right? We've all been trained differently, let's say. But just imagine if you're the oncologist or the radiation therapist, and you're given these three, segmentations. You're like, well, which one do I pick? What do I do? Do I just pick the average? Like what? Right? So that's a problem. That's a huge problem, and that's where you come in, right? What you want to do is create an algorithm that's going to automate the process and reduce that observer variability. Okay? It is absolutely trained on radiologists, which is called an imperfect gold standard. Okay? Imperfect. Because they don't know either. Right? If you knew for sure, like if you actually sampled cells, then that's a gold standard. But because you're training your data on thousands of cases involving typically many different radiologists, then what you're doing is you're creating kind of a really good radiologist. I'm not even going to say like superhuman. No. Just a really good radiologist. Okay? So think of it. Can your algorithm outperform all radiologists? Can your algorithm, if you train it on a foundation model, you're just a lucky person, you have so much data, and you're amazing, and you create an algorithm, can that algorithm outperform all radiologists? It's based on the radiologist, correct? No, you're right, you cannot. It's not possible, because your algorithm is based on your radiologist, right? And if I were to tell you my algorithm was 98% accurate, are you happy? Is 98% pretty good? What do you guys think? You guys happy with that? That's pretty good. That's good. But remember, that's 98% versus the imperfect gold standard. So that means it's 98% as good as any of your radiologists pooled together. So you are never exceeding the capacity of radiologists. So then you should all be saying, let's go home because machine learning is a waste of time. Correct? Because if I have a tumor in my brain, I don't want a 98%, I want 100%. Because 100% is my buddy, the radiologist. So if I'm not going to ask my friend to do it, why would I ask an algorithm that's going to be 98%? So why would I? Why is it's still such a fantastic tool? Why is it? Why is that? And actually, not to burst your bubble, but most algorithms are not running at 98%, right? So a lot of them are running at 92, 93. Anything over 90 is commercializable, right? So then why is that still okay? So, well, but we just said that it can't be better, really. It could be, you're right. But, in theory, it can't be better. So why am I still excited about AI? Sure, but the algorithm makes mistakes too because it's only 98% accurate. So it's making 2% error. Correct. That's exactly right. So what we've removed is the inter-observer variability between radiologists. So what you have now is a great radiologist available anywhere in the world, 365 days of the year, 24 hours a day. Wow. Right? That's the difference with AI. That single algorithm can standardize the approach across the globe if you were to do that. So then, yes, of course, sadly, there's still error. Of course there's still error. And yes, it is going to be not as good as my best friend, the perfect radiologist on the planet, the #1 radiologist that has ever lived, and he's my friend. It's not going to be as good as him or her. Fine. But he sleeps or she sleeps, right? And they don't work all the time. So that's the difference, okay? So if you're willing to accept a little error, which is exactly what we're doing now, globally, you're benefiting, wow, so many more people with a little bit of accepted error rate. And if not, what you're saying is, hopefully my friend had a good night's sleep before he read my scan. So there's even risk, even if I'm best friends with the best radiologist on the planet, I still have to hope they're feeling good that day, Whereas the algorithm, it always feels good. Okay, so that's the biggest, most important point. If someone pushes you on this, someone says you're wasting your time working in this field, because that's the answer. Okay, And it's real. I'm not lying to you guys. That's reality, right? So, contour variability, we just talked about. Guidelines reduce variability, of course. So standardization, so including AI, that's going to reduce variability. And AI auto contouring, same idea, because it's the same algorithm contouring every day, all patients. Okay? That provides standardization. Okay? And that's a good thing because it reduces variability. Okay, so what do we do for planning? Okay, so here's an interesting one. Is radiation gets absorbed, right? That's the whole point. It's energy, right? So when you irradiate something, it absorbs that energy and it disrupts it. That's in this case because the energy is so bad. And it can damage your DNA, which, as you know, even in the sun, if you get a sunburn, I would imagine maybe in India it's less common because you already have, built-in protection, having a darker skin tone. But it still happens, right? And that's exactly what the concept is here. Now, what do we do here? What's a Hounsfield scale unit? So a Hounsfield unit. So basically what the unit is doing is creating this interesting link between your CT and your planning. So a Hounsfield unit, you can see here, when you give it an actual number, so it's a unit, so it's arbitrary, right? We assign it. Air, which as you can imagine in a CT scan is black, right? Is negative 1,000. Whereas bone, so thick bone, is white, as you know, right? When you look at an X-ray or a CT scan, whatever is white is a bone. It's a hard dense. Soft tissue is in between. So all of these. So fat is negative 100, water is 0 right here. Soft tissues 30 to 45, okay? So that's kind of cool. We're taking the CT scan and we're assigning it, we're mapping it with Hounsfield units. And in doing so, what we can then do is determine our planning. Because just think, let's say you have a tumor in your bone, or you have a tumor in soft tissue. Which one would require more energy for disruption? The soft tissue or the bone? Yeah, the bone will require more energy, right? The soft tissue doesn't because it's very exposed, it's right there. So that's the purpose of the Hounsfield unit, is to help you, guide you, calculate for each pixel, literally, all of the Hounsfield units are per pixel, how much energy is required for you to irradiate the mass, okay? And what happens here, if you look at this graph here, on the x-axis is resolution, on the y-axis is variance, or you could call it noise. You can see that resolution versus noise, finer detail, higher resolution, means more noise. Okay? So what we want to try and do, right, is, this is the noise matched reconstructions, is what you want to try and do is find that sweet spot that planning is successful. Okay? So you want, that's what we're trying to aim to do here. Okay? And that's what the Hounsfield units provide you the ability to do, and of course the resolution of your CT scan, and the settings on your CT scan, and the windowing on your CT scan, and all that kind of stuff. Way too busy, you're not going to be able to read all this, I realize that, so I'll just walk you through it a little bit. So what this is just how, the Hounsfield units data is helping you plan the dose, right, the irradiation dose. So here you have your CT, your treatment planning, it goes into the planning assistant. You have primary planning, secondary verification. So why would you do that? So there's another use for AI, right? So why would you have backup? Like, why do you do verification, right? Because it's so crucial that you don't make a mistake, okay? So you always have redundant systems built in. AI is perfect for redundant systems, okay? So then you go through all this, primary and secondary, do they agree? So you see that's just a verification, like you do it one way, you do it another way, do they agree? Yes, we move forward, right? You plan and document. Of course, you have your clinicians agree on it. Can that bit be cut out in the future? I'm not saying now. But in the future, maybe, right? Interesting. It's an interesting thought, right? Do we really need a human coming in if this is fully automated? I don't know. What do you guys think? Be honest. Be honest. I'm not threatening you, Joe. But be honest. Like, does it really add comfort to you? Like, maybe it's comfort. Maybe it's the patient saying, yes, I still have a human involved. I feel better. But yeah, right. It's acceptance, right? Because the thing is do you really think a human's going to be able to pick out a very complex problem and say, oh, that's wrong? I mean, maybe today, because the systems are not fully integrated, they don't appreciate the entire process. That's the problem with AI. Is you're going to get hired to work on one piece of this entire planning, and you're going to be so proud of your algorithm, and it's going to work amazing. It will. But the problem is, if that piece of what you've just developed is not aware of all the other pieces in the process, then you do still need this physician. Because this physician, or biophysicist, whatever, medical biophysicists, they do know the whole process. They are the ones currently that can piece together everything, right, and say, yes, that's good, move forward. So that's where you need to be cautious, right? So when I say, can we cut them out? Yeah, today, no. But in the future, yeah. Because once everything is integrated and talks, then I'm going to be more confident that, yes, we're good to go. Does that make sense? Okay. How do we dose calculate? So dose calculations. So there are, I'm not going to go into detail on it, but as you can imagine, with every process, there are different ways of doing it, right? So there's one called a crude way, which is the pencil beam. Essentially, it's very simplistic, okay? You have collapsed cone, or what's called superposition. This one is more computationally complex, and therefore the solution takes longer for it to come out, all right? And then the last is Monte Carlo. So if you're in the world of statistics, Monte Carlo is iterations and complexity, very complex, and that takes the longest, okay, to simulate the answer. So let me give you an example of why we're doing this. So this is a representation, right, of where we want to target our radiation, and this is your dose. So GY here is a measure for how much dose is received, okay, whatever is the receiving doses, okay? And it's always good when they say that because what you emit and what you receive are different, right? So it's how much is received by the tissue. And so obviously here, as you can see, the numbers are, right? So this is the area where there's the most dose, okay? And if you look here, pencil beam versus Monte Carlo, right, the two extremes, all I wanted to show you is it's different, okay? And because pencil beam is simplistic, you can better appreciate that where you need the most radiation is different. Okay, oops. So the area is pretty good, right? Like in terms of where, but it's not as precise. It's just not as precise. So there's another example of how AI can be helpful, because this is very computationally heavy, right? So then, yes, if you can improve that process with machine learning, fantastic. And that's one of the target areas that we're working with, okay? So when you deliver the radiation, we've basically gone through all this, but essentially what I wanted to point out is it's 15 to 30 minutes. You also have to realize how long a patient can lie still for, right? So 15 to 30 minutes is actually, MRI is brutal. I mean, as I said, if you haven't gone through an MRI, you have to lie there for so long, and it's annoying, right? But you do. And so 15 to 30 minutes is actually pretty good, right, for patients to stay. And so that's what you have to plan in, all right? And you have to be immobilized, right? So then the scheduling becomes important as well. So just think on that one. There's another target for machine learning and artificial intelligence. Perfect. That's a perfect, I'm not going to say easy, but relatively easy task, right? Which is, how do we break up the delivery of the dose into the appropriate size and the frequency, right? So that the patient doesn't hurt too much, they can go home and regenerate a little bit, like literally, they feel better, and then they come back and get zapped again. So all of that can be modeled, right? And which one does this remind you of the most that we've talked about so far? In terms of types of machine learning. What does that seem? It could, something we talked about. What type of machine learning would that fit well? Supervised, unsupervised, or reinforcement learning? Which one do you think for doing this? Supervised learning? Unsupervised learning? Reinforcement learning? Yeah, reinforcement learning, right? State transition. Because that's what this is going to go through. It's states, different states, changing states. I get irradiated and I feel good or I feel bad, right? Like, there's all these, right? So reinforcement learning would maybe fit this quite well. Okay, so last thing, of course, things change, and we talked about that. So what's adaptive planning? I think it's the next one, yeah. Adaptive planning means, oops, the patient's changing. So what happens is they get scanned again, you do it all over. That's all it is, really. It's adaptive planning. But if you're doing reinforcement learning, knowing what was planned originally and what, is important, right? So what was planned originally, see how it's changed, give the adaptive plan, right? That's what this is. So it shows the original plan, and then shows the adaptive plan, see how it's changed. And this is the D plan. This plan here would have been what would have happened if you had not adapted, right? So it just shows to you like where you would have irradiated if you had not adapted it, which you needed to do, okay? And you need to do it because things shifted in the brain. Tissues have changed. Okay, so I kind of did this all along anyway, but just to summarize, automated contouring, no surprise, segmentation, right? Dose optimization and treatment planning, that's perfect for AI. Adaptive radiotherapy, we just saw it in the previous slide. Outcome and toxicity prediction, yeah, I mean, that's a tough one, eh? Wow. And that one's going to be like, who do you predict is not going to do well? Right? That's not an easy one. That's really not an easy one. As I said, if you had family members and stuff like that have unfortunately suffered from, cancer, you just really don't know how you're going to react. But yes, absolutely. If we could plan it, that'd be great, right? If you could give the patient, more warning, or more importantly, change the treatment plan in order to avoid, because that patient's more susceptible, right, to reacting poorly to radiation therapy. So then you would preemptively change the planning. Make sense? Yeah? I think that's it. Yeah, this is just showing you what we talked about this morning, right? Using NN-UNET, UNET, CNNs to be able to contour, okay? Which is what, this is all what Ernest went over today, this morning, but for pediatric brain tumors. But this is the same idea, okay? So this is your AI application. These things, these already exist that are being used for planning, okay? So these software already exist, okay? Adaptive radiation, as we said here, they're looking for taking another scan, allowing daily adaptive planning based, right? So the one I want to point out here, no, I think it's on this one, yeah, is you can use generative AI now to predict what could happen after first treatment and put that into adaptive planning, okay? So use generative AI in order to create if this is your beginning, right? You create the next, what the brain will look like after the session, or after a couple of days or whatever, right? And the next one. So that's simulation. That's pretty cool, right? So that's very helpful, right, for planning. Then you'll have reality, because you'll actually have to take a CT at some point. But you could also, through generative AI, actually predict what it will look like, which is very helpful for planning, especially for this one, right? So if you have a trajectory of a patient that shows that they're going to react more poorly to treatment, then you can help with this. So not only adapting what the next treatment's going to look like, but in this case, maybe even changing the plan once you see, to accommodate the patient. Yeah? That's it. So that's this work is from Atsuhiro Hibi, who is a PhD in human mind who graduated last year. He's a researcher from Nippon Steel. So the big steel company in Japan, who actually just purchased American Steel. It was a big deal. Anyway, he's back in Japan working for Nippon Steel, but he came and did a PhD with me very successfully. And this is kind of a shortened version of his work. You can see here, I already presented this for him actually in 2023 at a conference. So it's not like, he just graduated last year, but this is work he went through his entire PhD. So traumatic brain injury, if you don't already know, because you're engineers, many of you may not know the definitions in the clinical world, but a traumatic brain injury can be mild, moderate, or severe. A mild traumatic brain injury is something that you would know as a concussion. So if you hit your head playing soccer or football and you suffer, a headache, mild loss of consciousness, nausea, people will tell you, oh, you had a concussion, okay? But it's actually, clinically, it's termed a mild TBI, traumatic brain injury. A moderate TBI and a severe TBI is when you're hospitalized, okay? So then that's where, like, severe requires surgery, right? Decompression, you can do craniotomy, craniectomy, a whole bunch of unpleasant stuff, but is necessary for the level of damage in your brain. So in Canada, it's a big deal. So the numbers probably don't mean anything to you because our country is so small compared to India. So you'd be like, yeah, whatever, that's not even one of our states. And that's true. But I can just tell you in terms of impact, the number of people affected by traumatic brain injury in Canada is half the number of traumatic brain injury in India. How's that? Yeah, huh? Your rate of traumatic brain injury is about twice what ours is. And so for our country, it's a big deal. So I'm going to guess for India, it's a big deal, right? Because you have even more of it, all right? The challenge that we're facing, did I just skip through? Oh no, yeah, I kept it really short. So the challenge that you face with traumatic brain injury is prognostication. Okay, so prognostication, let me just make sure, yeah. So prognostication means, how am I going to be? Right, so you hit your head, or mom hits her head, falls over, she has a bad hip, she's older, she falls over, she hits her head. So how's mom going to be? That's a very important question, correct? That's what everybody wants to know. Very few people want to know, is it a mild TBI, moderate TBI, or major TBI, severe TBI. No one asks that. They just want to know, how am I going to be? And how long? Right? So that's prognostication. How am I going to be? And that's actually very challenging for machine learning to be able to predict that. And I'll explain why. So in the world of traumatic brain injury, 6 months post-injury is kind of a marker, kind of a thing, okay? In cancer, it's 5 years, right? If you're 5 years free of cancer, it's a big deal, right? Yay, you celebrate. In traumatic brain injury, you want to know how you're going to be in 6 months. That's meaningful, all right? And the way it works is, you know, in what we need to do when we do prognostication is we need to work with multiple different data sources and types. And that's why it's multimodal, okay? And so we have the CT scan, which is the bread and butter of the first line, right? For when you hit your head, you're going to get a CT scan. If you go to emerge, if you don't, then you don't. But if you actually go to a hospital with a suspicion of a head injury, they'll perform a CT scan. That's the number one thing. And then you also have clinical data and lab data. So clinical data will be how you present, history. Have you done this before? So if you're in sport, maybe you've done this before. We need to know that, okay? Because if you've had a previous injury, you tend to have a worse injury again if you hit your head again, okay? The lab data is, there are some markers that are interesting to know, glucose levels, hemoglobin levels, you know, that are in your blood work, that are also associated with traumatic brain injury, okay? So we need to add all this data together in order to decide at 6 months that we're going to have a favorable outcome and an unfavorable outcome, okay? And that's tricky for an algorithm to decide that, and we'll go into the fun bit of saying why. And why do we need it? Why would we need it before it happens, right? So if you're a physician and you know, someone asks you, how am I going to be in 6 months? You could always say, well, just wait and see in 6 months. You know, I don't think you're going to be very popular, right? So the reason for it is because you need it for treatment planning, you need it for disposition planning. So patient disposition means where is the patient in the hospital? Patient disposition. So I'll tell you a little secret about healthcare professionals, okay? It's a job for them. Okay, they love their patients, don't get me wrong, but it's a job. So when they have a patient, the most important thing they want to know is what do I do with the patient? So if they don't know what to do with the patient, that's a problem for them. So patient disposition, especially in emergency medicine, is where's the patient go? They're not staying here because this is an emergency ward. I need to know where they go. Am I sending them to internal medicine? Am I sending them to surgery? Or am I sending them home? But they're not staying here. That's patient disposition. And the last one is rehabilitation planning, which is very important because you need to know what does the patient need to do in order to do better in the long run, okay? So that's pretty complex for an algorithm to know, right? And the challenges in prognostication, of course, is that, once again, specialized expertise is not always available. That is really, traumatic brain injury is a problem in that sense because the only people who really see the outcome of these patients tends to be surgery, so neurosurgery. All of the mild TBI, they get sent home. Some of the moderate TBI get sent home quickly. So, it's difficult to actually know what the outcome is. And so that brings in for you, who's going to be training an algorithm, it makes it difficult for the algorithm to learn that. Manual CT assessment is time consuming and you need an expert. So you either need a neuroradiologist, so not just a radiologist, but a neuroradiologist, someone who sees, these kind of brain injury CTs a lot. Or you need a surgeon who sees these a lot. Emerge physician, they see it a lot, but are they experts? Depends on who you're dealing with. And so that takes a lot of time. And there's also a lot of waiting. Because depending on when you hit your head and you show up in hospital, there's going to be different levels of staff that are going to be available. And so very often the neuroradiologist is not available if it's in the middle of the night. So they'll come on and they'll report later. But that's a problem if you have a very severe head injury. You're bleeding. And so you don't want to be waiting for hours and hours and hours and hours and hours to find out that, you got to do something. So that's one of the biggest problems, is waiting for someone to give you an answer. Because the emergency physician wants to decide what to do with the patient. Do I send this patient home or not? Right? They want to know, right? And they're going to wait for the radiology report in order to make that decision. Okay, this was our study population. So interestingly, thank you, India, there's a very large database called Center TBI, and there's also a very large database that's called Cinter TBI from India. So we benefited from your database. The one we trained on was Center TBI, and this is just the patients that we use. I'm not going to go into detail because, as I said, we're going to go through this quickly. But we trained on those patients, and then we tested external validation on Cinter TBI, which is a similar data set from India. All brain injury. Okay? So we're going to go into a little bit of algorithm here. So our algorithm was taking our data, extracting clinical variables, so age, pupil reactivity, motor score, which is classic, right? Taking the lab variable, as I said, glucose, hemoglobin, and then the raw CT imaging, right? And we're trying to put this together. So where you're like, oh, well, how do I do that? Yeah, it's not easy. So this data, clinical variable, is numeric. Lab variables, typically numeric, of course. Raw CT imaging data. Not only imaging data, now you guys are experts. It's 3D imaging data made up of multiple slices, multiple views, planes, right? Multiple windows. Remember for CT? Windows. So all this information needs to go in together. So what we did was to take into account this data, we simplified it and moved it into a validated score. IMPACT is a validated traumatic brain injury score. So it's now a scalar value. And we brought it together into a multimodal 3D vision transformer. So VIT, right? 3D, because we have a 3D tensor. And we merged it with a scalar. So what we did is called augmented early fusion. So fusion means bringing the data together into a model. But there are different types of fusion. What we did is the classic early fusion, which means bringing these values together before modeling and then training the model, VIT, for your outcome, which is the probability of binary in this case, a GOSC score, Glasgow outcome score, at 6 months. Okay, so binary, yes, no. You're going to do good, you're not going to do good. The reason we couldn't do all levels, all 8 levels, was because, very simply, we didn't have the complete data. The data was sparse. We had data sparsity. So meaning that some of the data, some of the levels, we didn't have very much data. So in order to get a full complement, a full score outcome, we would need more data in order to train it. And so actually that's what I'm working on with a student right now in France. And we're doing synthetic data to augment those levels that don't have enough data, okay? But in this case, we grouped it for yes, no. So here's your 3D vision transformer. All transformers work in patches, which ultimately represent what's called a token. So we have our patching, you have several embeddings. So remember, embeddings is what's called a latent representation. Okay, so for those of you guys that are already kind of dozing off in the early afternoon, a latent representation means something that's not measured, but that is a variable, okay, of interest. So latent variable. So we don't measure the position or the representation. These are, these patches are also going to give you embeddings, right? So there's multiple embeddings here. So you have the image itself, and then the position. position of the token, of the tokens, yes, of the tokens within the image. No, not each image, each path. It's tokenized. It's all tokenized, okay? And so then you get the position, because you're feeding it all into the model, right? So it needs a position. It needs to understand the position, because you have a 3D transformer, right? You have 3D, right? You have multiple slices. So you have all that positioning is this embedding. So a latent representation means I take something that I measure, okay? And I have a task I need to fulfill. So I could take into account all the data I have in order to perform that task. But that would be, wow, computationally difficult, right? So when you take a space, and you get what's called the embeddings, you're taking a representation of that data that you need in order to perform the task. That's probably the easiest way for me to explain it. And in that representation, you can have multiple types of representation. So in this one, there's the images themselves and the position. And what we do in the transformer is we're also blending in the scalar value, which is also tokenized. It's tokenized, okay, put into tokens, bits, and the positional value of the bits. All of that is merged together in what's called a fusion. So that's an early fusion, okay? And then, boom, into the classification head. Okay, that's your VIT transformer, right? With what's called clean self-attention. So self-attention is how transformers work. And then you put into your classification head is where you can then potentially actually work in clinical and lab variables. Yeah? Because you're doing classification at that point. Okay. So one of the, I'm sure you were all thinking this. You're like, wow, there must be a huge imbalance in your transformer. So if you weren't thinking that, don't worry about it. It's okay, because this is all new to you. But absolutely, think of it. You have a 3D representation of the brain. That's a lot of data, right? And you have a single dimension for the scalar value. So there's a huge imbalance, right, of input. So you have to weight it so that it works. So just to explain to you how we do multimodal modeling, that's what we have to do, okay? So that's how we correct it. So if you were thinking, wow, that's a lot of data coming from the imaging, and very little coming from the scalar value, how do you do that? That's how we do it, okay? So then, as I said, this is augmented early fusion. So to fix that problem, it's called augmented early fusion. So we augment this guy here, okay? In order to balance it, to better balance it. And there is no, I know you guys are going to ask, okay, how do you do that? What's the secret sauce? There isn't one, okay? Each modeling that you're going to do is going to require you to figure out that balancing. It's not the same for everything, okay? Every model. Okay, so what are our results? So when we did all this, we were comparing to what's called the Marshall score, the Impact Core score, the Helsinki score. These are all scores that do the same thing, which is prognosticate at 6 months. And we created an algorithm that matched them. I mean, it says it's better, 0.85. I'd love to tell you, yeah, we're so much better, but statistically, come on, it's about the same, right? So, are we sad about this? No, that's great. We're matching what currently exists for scoring prognostication at 6 months in validated scores. That's very important, right? So to be able to match that is fantastic. So if you just look at, in terms of what we want to do is break it down to how good it is in the various, levels, right? That's whole population, but then you break it down to mild, moderate, and severe. And when we do that, what we're looking at is, how does the baseline change into the developed, score? And, for instance, here we're reducing the failure to treat, right? So sensitivity, right? Sensitivity means, accurately picking someone out, was improved, right, in our developed thing. So reducing failure to treat. Failure to treat means, you're good, go home. Bye! If you have a headache in 2 weeks, come back, So that's failure to treat, right? So in this case, what we're doing is we're reducing failure to treat, which is really cool. And that's for severe. Severe is the worst, right? So severe means surgery, no surgery. That's severe. So reducing the fact that you're, not going to get, not getting surgery when you need it, that's pretty good. And then reducing unnecessary treatment is really good for mild and moderate TBI, right? Because you don't want to have a hole drilled in your head to decompress if you don't need it. That's a big deal. That's very invasive, right? So this just shows you. How no change in overall accuracy, right? It was the same, 0.85. Actually, there's some cool things to it, isn't it? So that's where you come into my world in statistics. Don't just look at the one value of accuracy, which is terrible. Overall accuracy alone is a horrible performance metric. You need to look at sensitivity, specificity. You need to look at area under the curve. You need to look, you need to look deeper into your values. I always say sensitivity, specificity, by the way, because I'm in the medical world. In the medical world, you always talk about sensitivity, specificity for diagnostic accuracy. If you're in the engineering world, you're going to be talking about, recall and F1 and all that stuff, right? But humor me for being in the world of medicine, it makes more sense. So this is just a good example where, hey, you go a lot of hard work, you get the same result, so you're like, bum. But no, actually, it's not. It's actually still good. And could we have realistically expected we were going to do better? Well, no, because our data is based on, center DBI that's scored by the clinicians. So, it is possible we could have done maybe a little bit better, because if we had figured out a way to manage the noise better or whatever, hypothetically you could actually exceed, because it's such a big data set and it's so diverse and there's so much variability. It's possible, but in general, if you don't see it, it's okay. And that's the reason we saw 0.85 over 0.83 or whatever, so there's a little bit better, but, it's probably not, right? Okay, that's it. So that